Good morning, everyone. It's so exciting to start third series of IAPC Academy lectures, and I'm really happy and honored to welcome Dr. SVS Deo, a good friend of mine and good friend of all the faculties at IRCH, and also good friend of IAPC community. He has been involved with the IAPC academic activities since last many years, but because of COVID since last 2 years, I think everything is disrupted, and so I thought that I should bring back Dr. Dev in the lecture series, and here he is. Dr. Dev is I think many of you must be knowing, he's heading the Department of Surgical Oncology at National Cancer Institute as well as at All India IRCH AIMS, New Delhi. He has been with us since last 25 years and he has got good experience of surgical oncology field in academy as well as in the clinical management. He is also in charge of Delhi Cancer Registry Program, and in these days this program is going on really well. He is president of Indian Association of Peritoneal Surface Malignancy as well as Association of Breast Surgeons of India. He has multiple areas of interest and he is doing really well in all the areas, that is multimodality management, organ conservation surgeries, oncoplasty, palliative surgical oncology, cancer genetics, database development, curriculum and training. He has got more than 210 publications, and most of the articles are published in the best journals of India, and he has edited also 2 books. So Dr. Dev, I think without wasting time, I really want everybody is waiting to listen you, and please go ahead, and we will be taking question answer at the end. Arun will be keeping a track of all the questions and answers, and we will take the question answer at the end. Welcome, Dr. Dev.
Thank you. Am I audible, Dr. Shishma?
Yes, you are audible. Yeah.
You can see my slides?
Yeah, we can see.
Good morning, everybody. At the outset, I would like to thank the IAPC Academy. I'm happy to be back interacting with the palliative care community of India. We had a long break because of COVID. I would like to thank Dr. Shishma, Dr. Archana, and IAPC Academy organizers for giving me this opportunity. So to kickstart this series of lectures, I've been given the task of discussing the surgical emergencies and concerns in palliative care. What is the role of surgical oncologist? So what I have done in this lecture, I have tried to, it is not a cut and paste lecture. I've just tried to compile all my experience related to the surgical emergencies in palliative care setting. And I've divided my lecture into the following sections. A little bit of introduction to oncology emergencies. What are the surgical emergencies in palliative care? Various types, management approach. And I've tried to include a lot of case scenarios because in these situations, similar problem, 2 patients, you may manage them differently. So case scenarios are very important. And in the end, I would like to highlight the challenges, what we face during the managing emergencies in palliative care. And also I would like to give some solutions based on our experience. Cancer, as you all know, is the leading cause of death and single most important barrier to increasing life expectancy in every country of the world in 21st century. It is the first or second leading cause of death by the age of 70 in 91 out of 172 countries, according to Globocon data. I'm not able to shift my slides. Yes, so this is the footprint of cancer figures right now as per Globocon 2018. Majority of the Western Europe, North America, it is the leading cause, and Asian countries, it is almost in second or third rank, and soon it will touch, according to predictions, at the #1 cause of mortality. But in Asia, what you see is because of the significant number of population, the number of cancer cases it contributes and the cancer mortality it contributes is significantly higher compared to Europe and Americas, despite having a lower incidence compared to Western countries. A glimpse at the cancer burden in India. Currently, we have almost 2.5 to 3 million cases, the prevalence. and 1/3 present with early stage, 1/3 with locally advanced, and 1/3 with metastatic. Common cancers you must be familiar because most of the time you deal with these cancers. I think 80 to 90% of the time in emergencies in palliative care or palliative care services, you deal with lung, head and neck, GI, and prostate among men, breast, cervix, ovary, and GI among female. So you need to at least learn the basic oncology management of these cancers. The common 8 to 10 cancers is very, very important because these are the type of tumors you often see in your day-to-day palliative care practice. And more than 2/3 of these cancer patients in India will require some sort of a palliative intervention, and a small proportion may also require a emergency intervention during the trajectory of the disease. Emergencies in the field of oncology, a good proportion of cancer patients may present with emergencies or semi-emergencies. Oncology emergencies are mostly associated with advanced stage of disease, and sometimes it can be a terminal manifestation of cancer. You must remember this when you deal these patients. An oncology emergency is an acute, potentially life-threatening condition that can develop directly or indirectly as a result of cancer or cancer treatment. Treatment is complex and challenging as far as oncology emergencies are concerned. It's more challenging than managing routine palliative care and pain problems because of various challenges which I'm going to highlight in my lecture subsequently. And in this short time, we need to go with a multidisciplinary approach. We may need different specialties need to be involved for managing oncological emergencies, especially surgical emergencies. And surgery may be required to treat some emergencies, and multiple factors can influence treatment decisions and outcomes. So how do you classify emergencies in oncology practice? It can be disease related or treatment related. Disease related, you can have systemic and metabolic effects of cancer. I am not going to discuss these issues because my topic is surgical emergencies. Then disease related is structural effects causing bleeding, obstruction, perforation. That's what I'm going to focus on. The second set of complications in oncology practice, what you see is treatment related. So already sick patient with advanced cancer following chemotherapy, radiotherapy, or surgery can have complications because of treatments that have been instituted. So you have to be very careful when you take history and assess these patients. Sometimes these complications may be because of the treatment they are receiving. So these are the metabolic complications, tumor lysis, hypercalcemia. I'm not going into the details, the common hematologic complications. So you should be familiar with all this. Sometimes the patient may be coming with a surgical emergency, but he may also be having the other treatment related toxicities or complications. So that can affect your treatment decisions. So you should be familiar with these conditions when you deal with the surgical emergencies. Patient may be coming with a perforation, but he may be having a neutropenia at the same time. Chemotherapy extravasation, gastrointestinal problems, radiation-induced toxicities. Now we are seeing a lot of targeted therapies and new advances coming into field of medical oncology. So you need to be familiar with the side effects of new treatments. They have a different set of side effects. Structural issues, mainly superior vena cava syndrome, spinal cord compression, and effusions. So this is a broad classification system which can be used to describe oncological emergencies. Now I will focus on the surgical emergencies in palliative care. The first and foremost which comes to my mind is obstruction because of the mechanical blockage of a natural passage due to growth of the tumor. So this can involve either a GI tract, biliary tract, airway, urinary tract. So these are the common sorts of presentation of tumor obstructing a natural passage. The second important surgical emergency is the bleeding. It can be due to tumor bleeding, coagulopathy. The bleeding can be external, bleeding can be internal. Third important surgical emergency is a perforation of a most commonly involving GI tract. Fourth is effusions. It can be either ascites, pleural, pericardial. You can also have patients presenting with pathologic fractures due to metastasis, spinal cord compression, SVC syndrome, chemo extravasation, infection. All these are surgical emergencies. Patients can present to ER following treatment or after diagnosis of cancer. So what is the spectrum of surgical emergencies in oncology setting? So we don't have much literature, especially related to emergencies, surgical emergencies. But this is a very good review from Netherlands, where they have reviewed the spectrum of emergencies presenting to ER in oncology setup. So here you see the most common is obstruction. Almost 86 patients out of 300 they presented with obstruction. Most of the common causes include GI tract, colorectal, biliary, small intestine, airway, and gastroesophageal. So this will give you a glimpse of what are the common sort of emergencies you can encounter in a emergency practice in palliative care. But of course, this also depends on the type of cancers you deal. That's what I was telling. The common cancers in India are different. So the spectrum is also likely to be different. In this series, if you notice, hardly any head and neck cancers. So, but we do often see here 20 to 30% of our emergencies coming with head and neck cancers. So, but this will give you an idea what are the common other cancers can present with emergencies. The second important group which they have shown is the perforations, followed by bleeding, pathological fractures. And this is the frequency of surgery that has been utilized in these acute surgical emergencies, because just remember, surgery is not the answer for all surgical emergencies. Sometimes you may go for a conservative management, non-surgical interventions. So the frequency of surgery varies from 60 to 70%. That is the utilization of surgery in surgical emergencies in oncology setup. And the mortality is in the next column, followed by multidisciplinary management, which was possible in emergency setting. This is very important because you see the percentages vary from 10 to 40%. That is the frequency on which they could utilize the multidisciplinary management in an oncology emergency. Common cancer types, of course, this reflects the more of a Western cancer spectrum. And these are the previous treatments, post-treatment status. Around 30% received radiation, 30 received chemotherapy, and 60% had history of previous surgery. Coming to the clinical spectrum, all the palliative care physicians should be familiar. It can be classified according to the sort of a location of presentation. Maybe emergency in an already hospitalized patient. So that is one situation. So where your approach, your reaction, your reflexes are different because you are already dealing with the patient. You know the background of the patient. So a hospitalized cancer patient can develop an acute emergency. The second presentation is presentation to the emergency room, which is more challenging. You don't have the history, you don't have the background. Suddenly patient can come to the ER at an odd time. So that is where the real challenge comes in managing these patients. Coming to type of presentation of emergencies, surgical emergencies, sometimes the patient with cancer can present as an acute emergency at the first time. Suppose a tracheal tumor with an airway obstruction. He may not have a proven diagnosis of cancer. He may not have a history of receiving treatment for cancer, but it can be a first presentation. Just remember this. And an acute emergency while undergoing treatment. So that is another situation, which is more complicated. And the third situation is emergency following completion of treatment, during follow-up. It can be a relapse, it can be a treatment-related complication. So just try to get a glimpse of what kind of presentation is the patient is presenting with as an acute emergency while undergoing treatment, or emergency following completion of treatment. So your approach will be different when you deal with these patients. Surgical emergencies in palliative care setup is challenging to manage because there are various factors which can influence the treatment decisions, which includes disease-related factors, treatment-related factors, patient-related factors, and what is the availability of expertise at your own center. This is the most important factor. So always you need to quickly analyze these four factors when you decide treatment in an emergency, surgical emergency in the palliative care setting. What are these factors? The patient-related factors: age, comorbidities, performance status, expected life expectancy, desire and expectations of the patient and family. So you just need to quickly analyze these factors within maybe 1 minute in emergency. Disease-related factors, just be systematic. Always remember this for especially the students of palliative care. So in emergency, you will not have much of time. So within 1 or 2 minutes, you need to just get this important checklist and the points to decide the treatment. Disease-related factors include extent and burden of disease, prior therapy, whether the disease is salvageable or not. Quick points, 3 points. Treatment related factors. What are the available treatment options at your center? Okay, don't go about guidelines and all those things. First, see what is available at your center. Surgical versus medical options, less versus more invasive options. And what is the availability of expertise at that particular time, at that particular point. What are the guiding principles? We have a set of guiding principles when you manage these patients. The nature of emergency, whether it can be reversed, the effect of treatment on the overall condition of the patient, treatment options available, what are the risks and benefits of that particular intervention. The goal should be very clearly well defined when you offer some treatment in these patients, and patients and caregivers' wishes, and it should be a shared decision making. Surgical decision making in palliative care is a holistic decision making. It is not a pure mechanistic, one time, problem oriented decision. You come with obstruction, you operate. It is not the solution in a palliative care setting. It has to be holistic decision making, taking all the factors which I mentioned earlier into consideration. So the same obstruction in a non-cancerous patient, the surgeon's approach may be different, but in a palliative care setting, it may be different. We try to offer minimum possible intervention, simple procedures, avoid long hospital stay, avoid morbidity whenever feasible, explore non-surgical options if available, and you should take calculated risk. I will give you 2 case scenarios here. The first case scenario, we have a 58-year-old male patient, known case of rectosigmoid junction cancer under workup. He presented to emergency with a progressive constipation, abdominal pain, distension and vomiting of 3 days duration. Clinical assessment revealed features of large bowel obstruction due to colon cancer. CT scans revealed a localized rectosigmoid growth with a solitary liver metastasis. Just remember this. He is untreated, fresh patient, 58-year-old male, rectosigmoid growth with a solitary liver metastasis. He has a good performance status, is hemodynamically stable. This is the CT scan. You can see a resectable growth in rectosigmoid, and we have a solitary metastasis in the liver. So it was quickly evaluated by the emergency team. The surgeons were called and they reviewed the CT scan, and the assessment was done, and the decision was taken to do emergency laparotomy. A sigmoid colectomy was performed. Patient condition improved. Systemic chemotherapy was given for 6 months, and patient was taken up for stage right hepatectomy with a curative intent after chemotherapy. So this is the plan which was implemented in this patient. Let us see case scenario 1, 2. Here we have a 74-year-old female, a known patient of metastatic colon cancer undergoing chemotherapy. She presented to emergency with features of large bowel obstruction. CT scan revealed again a similar growth, but she has multiple liver metastases not responding to chemo. She has a poor performance status. She has a chemo-induced hematological toxicity. Hemodynamically, she was unstable. So just remember these points. Same rectosigmoid growth, liver metastasis, but the clinical background is totally different in this scenario. This is the CT scan, multiple bilobar liver metastasis. So patient was reviewed by MDT again. Emergency gastro consultation was obtained for this patient. A colonic stenting was offered to relieve the obstruction, and she was managed with supportive care. So once the obstruction was relieved, patient was re-evaluated by MDT after 10 days. And after a detailed discussion with the family, a decision was made to manage the patient with palliative intent only with symptomatic treatment. So what are the lessons we have learned from these 2 patients? Similar problem, rectosigmoid growth, liver metastasis, but see the differences here. So if you do the analysis of decision making, age in the patient 1 is favorable, patient 2 is unfavorable. Performance status similarly is favorable in patient 1. Disease status, this is very important. In oncology, that's what I was telling you, need to learn about at least 10 common cancers, the treatment approach, the oncology part. All metastatic patients are not for palliation. All metastatic patients are not for non-aggressive or non-curative treatment. Nowadays, because of the advances in the field of oncology, we treat patients even with a limited burden metastasis. We call them oligometastasis with a curative intent. So always keep this in mind. We don't just tell them that there is no treatment, you go for palliation, because a limited metastatic burden, especially certain tumors like colorectal cancer, still can be treated with a curative intent. So the first patient had a single liver metastasis, which falls under the category of oligometastasis. Whereas on the other side, you see the second patient, she has multiple liver metastasis, which is not amenable for cure. Prior treatment factors, no therapy in first patient, chemo with toxicity in the second setting. So the surgical decision making, if you do the analysis, benefit is more than risk in the first patient, risk is more than benefit in the second patient. So that is how you do the situation analysis in these patients. So let's move to the obstructions. When you see the patient with obstruction, you need to quickly assess the following issues in an oncology setting: level of obstruction, whether it is upper GI, small bowel, large intestine, colon or rectum, because management is different. Type of obstruction, whether it's a partial obstruction, complete obstruction, or a recurrent obstruction. Sometimes patient keep on coming to ER. So you need to keep this in mind. Number of obstructions is also important, whether it's a single site obstruction or multi-level obstruction. Mostly you see in ovarian cancers, which is a terminal event, multiple levels of intestinal obstruction. So here your approach will be different. A single site obstruction with colon cancer, your approach will be different. Upper GI blockage, your approach will be different. Small bowel obstruction, your approach will be different. So just you need to assess these factors when you see these patients in emergency. What are the MDT requirements? You need a surgeon, medical and radiation oncologist, palliative care physician, interventional radiologist, gastroenterologist, stomatherapist. So this is the ideal team when you deal with a patient with obstruction. Conservative management includes nil oral, nasogastric decompression, IV fluids, total parenteral nutrition, supportive care. It can be tried in partial obstructions prior to surgical preparation, patients not suitable for invasive therapies, or patients with limited life expectancy. Non-surgical interventions include image-guided gastrostomy, jejunostomy for decompression and feeding. Endoscopic interventions. In the last 10 years, you are seeing introduction of PEG, endoscopic stenting, endoscopic laser luminization can be utilized in certain situations. These are suitable for patients with advanced disease, moderate life expectancy, unsuitable for major surgery, or as a bridge to surgery. You can just optimize the patient by doing a stenting and subsequently take them up for surgery. So remember the non-surgical interventions. These are various examples of utilizing a stent in an emergency situation for upper GI or colonic blockage. You need a good gastrointestinal interventional gastroenterologist to execute these kind of strategies. Surgical management includes resection and anastomosis, bypass procedures, diversion. So these are the various types of surgical procedures which can be offered to patients with obstruction. In a good fit patients, we go for resection and anastomosis, and bypass diversion like a stoma is done in patients with advanced disease, unresectable with a poor general condition and a poor prognosis. So these are various depiction of various surgical procedures that are offered in emergency situation. So this is an example of a bypass. We don't attack the tumor, but you open a passage here. In a growth of ileocecal junction, you do a ileotransverse bypass so that you bypass the obstruction. It's a simple procedure. So the take-home message for obstruction is access. First, you need to assess the type of GI obstruction, assess overall disease and performance status, desire and wishes of the patient and family, review treatment options available at your center. Surgical versus non-surgical options you have to decide first. Judicious and balanced intervention is the next step. Biliary obstruction can be caused by pancreatic, gallbladder, periampullary carcinomas. Patients can present with jaundice, cholangitis. Management is relief of blockage along with antibiotics. You have two options here: ERCP with stenting for low blockage, PTBD for high inhaler blockage. Remember, PTBD has got a high morbidity because of the external drainage system, and rarely we also offer surgical bypass. So these are examples of ERCP and stenting for surgical obstructive jaundice. And this is a PTBD on the right side, but this is a high risk of cholangitis because of the external drainage system. And rarely we also do a surgical bypass for duodenal obstruction and jaundice in patients with pancreatic cancer. Airway obstruction is a common life-threatening oncology emergency, mostly associated with advanced head and neck cancers. It can be a chronic airway obstruction, acute, or sometimes you can see acute and chronic. It's mostly attended by ER teams because of the time constraints. And I will just show you some case scenarios of airway obstruction. The critical factors when you manage a patient with airway obstruction is severity of obstruction, cause of obstruction, whether it is intra or extraluminal, level of obstruction, whether it is the laryngeal block, proximal or distal trachea, extent of obstruction, access to airway, whether you can access the airway through the neck or endoscopically, and what is the expertise available. Case scenario one, this was happened recently last month when we were opening up after COVID. A 58-year-old female from Himachal presented with a thyroid cancer with past history of 2 surgeries, progressively increasing neck swelling and stridor to outpatient department. She was referred to Oncologist setup. She was hemodynamically stable. She had tachypnea, saturation was 90%. CT scan revealed tracheal obstruction due to thyroid cancer, infiltrating carotids and esophagus. So since she was stable, we took her for emergency tracheostomy and we planned further palliative treatment. You can see the CT scan here with the critical compression of the trachea. This is thyroid mass, and we did a tracheostomy. We had enough time to plan and do this procedure. The second, again, a 45-year-old male presented to ER with difficulty in breathing and hemoptysis. He had no history of cancer. Workup revealed a tracheal tumor obstructing the supracranial portion of the trachea with bleeding. So here we did a pulmonology consultation, emergency bronchoscopy, biopsy, and tracheal stenting was done for this patient. And subsequently, patient was taken up for a curative tracheal resection for a carcinoid tumor 2 weeks after the stenting. So here the situation is different. It's a tracheal tumor, low tracheal tumor. Tracheostomy is not going to give you solve your problem. Surgical resection is very challenging. So you need to tide over the crisis, get a diagnosis, then plan for elective surgery. So this is, again, an interventional pulmonologist can play a big role in airway blockage, especially low tracheal tumors. So stenting can be done in emergency situations to stop the bleeding and obstruction. Third scenario, a female again presenting with a breathing difficulty and stridor. She has a history of long-standing neck swelling, but we don't have a diagnosis. She was seen by ER team and anesthesia team. Patient was in respiratory distress. Emergency intubation was performed. Workup revealed a papillary thyroid cancer infiltrating upper trachea. Patient was taken up for elective total thyroidectomy with tracheal resection after 2 days. So this is again the picture of the same patient you can see here. It was a resectable tumor infiltrating trachea. We did a resection of total thyroidectomy along with tracheal resection. And patient was cured after this surgery. So that's what I'm telling. Every patient is different. So you need to get the clinical assessment very meticulously because your approach may differ for the same problem. So management of airway, the take-home message includes mostly it's a life-threatening emergency associated with advanced head and neck cancers. You have less time to decide. Main aim is to relief of airway obstruction. Critical team members in airway obstructions include ER physician, anesthesiologist, surgeon, and palliative care physician. Conservative management includes sedation, oxygen, steroids. Surgical options include intubation, tracheostomy, stenting, or percutaneous or open surgical tracheostomies. Next, we'll move on to bleeding. Bleeding is also a life-threatening oncological emergency sometimes. Bleeding from tumors can be either internal, bleeding within the lumen from GI tumors, external, especially from fungating tumors like sarcoma and breast cancer. It can be slow and chronic bleeding. The second type of bleeding, tumors eroding into major vessels. That is a life-threatening catastrophic bleeding. You can see this in head and neck cancers, thoracic malignancies, inguinal nodes eroding into femoral vessels. This is what we typically call a carotid blowout or femoral blowout. Patient presents to emergency with a dramatic sort of a blowout of major vessels. It is catastrophic and life-threatening. Or sometimes it can be treatment related because of chemotherapy, thrombocytopenia, DIC can also cause bleeding. And you can also have patients presenting with bleeding following radiotherapy, especially with radiation enteritis or radiation cystitis. So a quick history is extremely important. Management depends on the site, cause, volume of bleeding, hemodynamic stability, and what availability is available at your center, expertise available at your center. Non-surgical options include stabilization of patient with IV fluids, blood transfusions. Local pressure plays an important role, especially in external bleeding. Topical hemostats like NORAD or adrenaline can be used. Tranexamic acid, correction of coagulopathies, hemostatic radiation. These are certain options for non-surgical management of bleeding in oncology setup. We also have endoscopic interventions using upper GI or colonoscopy. We can thermocoagulate, laser, or do organ plasma coagulation of bleeding tumors. Cystoscopy can be offered in patients with hematuria, and we also offer endoformalin therapy for radiation cystitis. Simple options, just remember this, because every bleeding is different, your approach is different. Intervention radiology sometimes can be asked to intervene for doing angioembolization for bleeding. This is the best example is carcinoma cervix, where you can do angioembolization to stop the bleeding. Or we also do some packing of the vagina in patients presenting with bleeding of carcinoma cervix. Surgical management in bleeding includes emergency exploration, resection of a bleeding tumor if feasible, especially in breast, limbs, you can do amputation or removal of a breast for a bleeding tumor. Sometimes you go for ligation of the vessels. Like in head and neck, if you don't know the source, patient is bleeding in the emergency room from oral cavity or throat. What sometimes we do is we stabilize the patient, take the patient to the OR, and we do the ligation of external carotid artery. So that is one of the options to stop the bleeding. Or sometimes repair of the bleeding vessel is rarely feasible because the tumor destroys the complete anatomy. It's not possible to repair the bleeding vessels. And packing is one of the options, desperate options in certain situations. So these are a few examples. Again, bleeding tumors presenting to emergency here, a large sarcoma with a massive bleeding. So we have to go ahead with emergency 4/4 amputation. A huge chest wall tumor, a breast tumor here, fungation and bleeding. Again, this was managed with the chest wall resection and radical excision following and reconstruction. This is what we do in head and neck cancers. In emergency, either you can do angioembolization or you can go for external carotid ligation here. So because most of the branches to oropharynx, larynx, and oral cavity comes from external carotid, so what we do is just ligate that vessel. So bleeding take-home message, it's a life-threatening emergency, a limited time to decide. Critical factors include type, cause, severity of bleeding, status of the patient, what is the underlying cause, and critical personnel who needs to be around to include ER physician, a surgeon, anesthesiologist, and palliative care physician. First aid, first you do the first aid, then decide for surgical versus non-surgical intervention because you will have less time to react. Next is perforation. Mostly in patients, you see perforation in mostly in patients with advanced GI cancers. It can be life-threatening if not optimally treated because it can lead to peritonitis and septicemia. So you must also remember various types of perforation in oncology setup. The perforations can be due to tumor infiltration, infiltrating the complete thickness and perforating. That is, a gastric cancer can perforate, colon can perforate. The second situation is perforation of a distended bowel due to obstruction. Suppose there is an obstruction in the ileocecal junction and the patient has got a massively dilated rectosigmoid tumor with a competent ileocecal valve. Patient can have a massive dilatation of the large intestine and cecum, which can just perforate. Post chemotherapy, you can see in lymphomas because they are very chemosensitive. A GI lymphoma patient after receiving chemotherapy, suddenly they can present with a perforation because the tumor melts away, leading to perforation. And we also see in cancer centers sometimes endoscopy. While doing endoscopy in these patients, you can have iatrogenic perforations. So the typical presentation, acute abdomen, dilated bowel loops, gas under the diaphragm, just remember this. And here in emergency exploration, revealing a perforation in small intestines. Perforation is a surgical emergency. Treatment depends on the patient and disease-related factors. The non-surgical treatment options include peritoneal cavity drains only. This is offered in extremely critical patients with advanced disease where you don't want to operate. You can put peritoneal cavity drains under local anesthesia or under radiological guidance. Surgical options to manage perforation include, and these are generally offered to fit patients and who are salvageable, which includes resection, repair, bypass, along with diversion of the stoma. Another emergency is the tracheoesophageal fistula because of perforation of esophageal cancer, which is also an oncological emergency, which can lead to aspiration, pneumonia, sepsis, advanced esophageal cancer infiltrating trachea. You can have various situations, maybe a tumor perforating into trachea or post-CT radiotherapy or chemoradiation. You can also have tracheoesophageal fistulas. The treatment options include endoscopic intervention or surgical intervention. Mostly these patients are offered endoscopic interventions. So this is an example of tracheoesophageal fistula here. There's a communication CT showing between trachea and esophagus. And this is upper GI endoscopy here, a bronchoscopy here. This is upper GI endoscopy showing TE fistula, and this patient was managed using a stent. The stent will block the fistula. You can tide over the crisis and subsequently take up the patient for specific oncology related treatment. And sometimes these fistulas can heal with chemoradiation also. The next emergency which I would like to cover is spinal cord compression, which is an oncologic emergency with a potential for severe morbidity. Just remember this. 5% of cancer patients, especially with bony metastasis originating from breast, lung, myeloma, prostate, can present with sudden onset backache or lower limb symptoms like root pains, weakness, urinary symptoms, tingling and numbness. If untreated, it can lead to paraplegia or quadriplegia. Timely diagnosis and treatment is very critical. Management can be either medical, radiation, or surgical. We have various treatment options depending on the type of spinal cord compression. We need to have a high index of clinical suspicion, and normally CT scans or X-rays, the MRI is the treatment of choice, investigation of choice, because it can reveal the vertebral metastasis, extent of destruction, and can also show the amount of cord compression. So if possible, do an emergency MRI, because plain X-rays may not show bony metastasis unless you have more than 50% destruction of the bone. Management, again, is a multidisciplinary approach, which includes palliative care physician, medical oncologist, radiation oncologist, and a neurosurgeon. Urgent intervention within 24 hours is mandatory in these patients. We can use corticosteroids, radiation therapy, or surgery if indicated, systemic therapy in chemosensitive tumors, or hormonal therapy in hormone-sensitive tumors, and we have other options like vertebroplasty, bisphosphonates, etc. Indications of surgery in spinal cord compression include when you need a tissue diagnosis, unknown primary with a bony metastasis. You cannot treat this patient, so we need a tissue diagnosis. That is one situation. Deterioration during palliative radiotherapy. Bone destruction with spinal instability is again an indication for surgical intervention. And cervical cord lesions, you have to be very careful. Early surgical intervention is recommended. Surgery commonly includes a laminectomy and decompression or spinal stabilization. So these are a few examples of spinal stabilization here. Emergency situations, mostly done by neurosurgeons. So what you do here is decompression, do a laminectomy, relieve the pressure on the spinal cord, but at the same time, you need to stabilize the spine, the destroyed vertebral bodies, by using either a rods or plating systems. You can stabilize the spine. These are various examples here, how this spinal stabilization is done. So a case scenario again of a spinal cord compression. This again we have recently experienced. I think Dr. Shushma was also involved. I was also called for a short while to assess this patient. A 58-year-old female doctor treated for locally advanced breast cancer 3 years back on adjuvant hormonal therapy. She was disease-free during COVID. She was doing well, and follow-up assessment was done 1.5 years back. She presented to oncology center suddenly one day with a palliative care physician with a bilateral lower limb pain and backache following a yoga. So she thought it is because of yoga, mild backache. She sat at home for 2-3 days, tried painkillers, but she started having lower limb symptoms. Remember, she was disease-free otherwise. So she was admitted for assessment by the palliative care physician in our center. I was called for assessment, a preliminary assessment. A medical oncologist was also reviewed. Since there was a suspicion of a spinal cord involvement and rapid progression of symptoms, there was a high degree of suspicion. There was no evidence of loco-regional relapse. The emergency MRI was ordered for by the palliative care team, and which has revealed extensive skeletal metastasis with spinal cord compression. So we sought urgent initiated medical management, bed rest, spinal brace, steroids. We also sought urgent neurosurgery consultation, and she had emergency surgery, decompression followed by fixation of the spine, and urgent medical oncology consultation was sought. She was started on hormonal therapy, And the radiation oncology was also consulted for subsequent radiotherapy. She was started on second line hormonal therapy, and palliative RT was planned after 2 weeks. Patient was discharged on day 7. So this is the ideal case scenario where she had access to a good center. She had access to all the expertise. Within 1 day, I think, because of good coordination, everything could be sorted out, and she walked back home. But on the other side, you have certain patients being misdiagnosed, mismanaged, can end up and present, excuse me, with a paraplegia or quadriplegia. We see a lot of patients in outpatients. The pains, the backaches being treated as sciaticas or backache, non-specific backache. They are on medication for a long time, progressive neurological symptoms, and suddenly they can present with paraplegias. So timely intervention can give you excellent outcomes. Superior vena cava obstruction is rare but critical oncological emergency, mostly due to mediastinal tumors, bronchogenic carcinoma, lymphomas. The mechanisms of superior vena cava obstruction include extrinsic pressure, intraluminal thrombosis, or direct invasion by tumor. Common clinical signs and symptoms include swelling of the face, neck and arms, upper half of the body. You can have dilated veins in the head and neck and upper chest. Patient can present with dyspnea due to tracheal edema, headache, visual changes, dizziness because of cerebral edema. Emergency treatment is mostly offered by the multidisciplinary team in the ER room. Patients can be put in an upright position. You can offer benzodiazepines to decrease the anxiety. Steroids and furosemide diuretics can be used to decrease the edema. You can offer oxygen supplementation. And certain chemo and radiosensitive tumors, we can offer emergency chemotherapy or radiotherapy like lymphomas and all. They can see a dramatic response. Surgery is rarely offered, especially it can be offered in resectable tumors causing SVC obstruction. And nowadays you can also have endovascular grafting by interventional radiology. You can relieve the SVC obstructions. So these are a few examples of a SVC surgical approach, which are not commonly done, but you should remember these are the various options to manage SVC obstruction. So these are the major surgical emergencies which I wanted to cover. There are a lot of surgical emergencies. It is not possible to cover every emergency in this short time because we have only 45 minutes. I think I have another 10 minutes time. So I would like to discuss some important general aspects, the principles of management, how to approach, what are the challenges and what are the solutions in surgical emergencies in palliative care. So coming to outcome measures and tools, you see there are various scales and tools which have been used to assess the outcomes. So nowadays everything is guidelines, scales, tools, but sometimes it is the experience and your wisdom which is more important than having some numerical scales. We have various scales like patient-reported quality of life, assessment of symptom response, assessment of overall impact. These are mostly used to assess the outcomes of palliative surgery. But we don't have any good scales to assess the emergency outcomes. So palliative surgery outcome score is one of the systems which can be utilized. Good to excellent palliation is defined as score of more than 70%. I'm not going into the details of these scoring systems, but what I would like to highlight is there is also literature which says physicians' forecast was significantly better than original scoring system. Prognosis made by physicians are superior to objective models. What it actually highlights is your experience, your wisdom, your analysis in that particular patient is more critical than applying a numerical scale. So you should be aware of these scales, but every individual patient is totally different. So coming to few of the challenges which we come across in surgical emergencies in palliative care, it is the most challenging field in the oncology and palliative care. The emergencies in palliative care is the most challenging because multiple factors need to be considered for decision making. You have less time for patient evaluation and MDT consultations. You don't have that much of time like elective palliative case. You have limited time to explain options and outcomes, resist work-says benefits to the patients and the relatives. Patients' desires and wishes is difficult to assess in emergency situations. Communication issues. Emergencies because of lack of preparation, odd time of presentation, absence of senior staff, lack of information, absence of crucial family members. All these factors will complicate the communication issues. Who should communicate? whom to communicate, what to communicate. These are very, very important aspects which we need to deliberate when you deal these emergencies. Communication issues among treating team members is also extremely important. Whom to consult, whether the radiation oncologist or the neurosurgeon or the general surgeon or a head and neck surgeon. You should be very clear when you deal with these emergencies. Different treatment options and opinions can lead to conflict and affect care pathways. So we need to be very careful. Consent and medical legal issues is also a very big challenge in surgical emergencies in palliative care, because we need to make complex decisions. There are no standard uniform guidelines for managing emergencies, especially in individual patients. There are broad guidelines which are available, but there is no uniform sort of applicable guidelines for every situation. We can have contradicting multiple opinions. Some patients and families are prepared for any eventuality, but at the same time, some families and patients are not mentally prepared. You need to make individualized decision making. Difficult to consent because of time constraints, complexity, and consequences. Shared decision making and proper documentation is critical. So to avoid medical legal issues. So always do a good documentation. Moral and ethical issues. Emergency, remember, can be a terminal event in certain patients. It can be a terminal event. Obstruction in a heavily treated ovarian cancer, it is a terminal event. So whether to intervene or not, you have to take a call. There are moral and ethical issues involved. A carotid blowout in advanced head and neck cancer can be a terminal event. So whether you need to jump and operate on this patient or just wait and let the patient pass off is again a moral and ethical issue. Advanced and terminal cancer patients, interventions can prolong suffering and agony. Aggressive interventions may cause harm in some situations. We prefer less invasive and simple options in such situations. Extremely critical and terminal cancer patients, sometimes you may have to adopt an approach for passive euthanasia. So you must be able to recognize these situations. Team, so what are the solutions? So these are the challenges, but I would like to highlight some solutions also. These are last, I think, 2-3 slides. So how to approach emergencies in palliative care setting? The best solution is to have a team and protocol-based approach on oncological emergencies. You have to develop institutional SOPs and guidelines for managing common oncological emergencies should be available in every center. So what are the steps that need to be taken? And I would also like to encourage you prepare a checklist of critical factors for every oncological emergency, which includes, which I have highlighted, I think just one-page form. We just need to have a checklist, patient factors, disease factors, emergency related factors for that particular problem, what is the MDT requirements, treatment options, consent, advanced directives availability or not, and objectives of the treatment. Prepare a quick checklist, develop institutional SOPs, guidelines, have a team and protocol based approach. You should not leave a junior most person fighting alone in the emergency. That's what I mean to say. And you come in the morning and start picking up problems or the issues, how it was mismanaged. So just prepare them for these emergencies and you can adopt these kind of approaches. Develop skills for a quick and good decision making in a complex situation. This is a mental sort of a process exercise. Every physician need to be ready. A good temperament and mental balance is required in handling these problems. Rapid patient and problem oriented assessment. You should be able to do a mental assessment quickly. It is not like a routine palliative case. You have half an hour to do the assessment of the patient. Quick gathering and analysis of all relevant parameters. It is not like taking history of a long case. Within 1 or 2 minutes, you should be able to pinpoint the critical signs, symptoms, and arrive at a quick diagnosis. Multitasking or role definition of team members is extremely important. You are in a busy hospital, a patient lands up with an emergency, oncological emergency. Either you should be able to do a good multitasking or you delegate role definition of team members, starting from first aid. First, you attend the patient, then decide what consultations you want to make. Simultaneously start working up for a CT scan or MRI and keep communicating with the family and the patient and the other team members. Keep doing documentation and keep treating. What happens is you stop one, you start doing other. You want to do the documentation, you stop the treatment. So you should have these skills. Multitasking is very important and you should do all these tasks simultaneously. First aid, attend the patient, The most of the time, the common complaint is patient says for half an hour, nobody attended me. So they were making preparation for the documentation, registration, etc. So first aid, consultations, workup, communication, documentation, treatment should go simultaneously in emergency situations. Mental rehearsal and practice of complex decision-making algorithms is extremely important. You keep watching your seniors join certain emergency situations and keep watching all the situations, how these things are being done. So the mental preparation and rehearsal is very important. Situational awareness and flexibility of the approach is extremely important. You have to be flexible depending on the case, the time, and the situation, and be aware of the situation in which you are working. Communication and documentation is extremely important in oncological emergencies. There's a need for a good leadership and team approach, clear chain of command, clarity of thought process, extremely clear thought process, clear communication. These are all easier said than done, but this you try to achieve these things. With experience, you will gain these qualities. Clear communication, keep the short-term and long-term objectives in mind. Uh, and adequate and timely documentation with details of discussion. Always do this. Don't miss this part, along with logic and explanation for each decision taken. So every step you take a decision, remember that and you document it, why the decision was taken at that particular time. The key to success in surgical emergency and palliative care is a multidisciplinary seamless team approach. So it should be a seamless team approach. That is the key word which I would like to emphasize. Supervision and guidance of senior members whenever is feasible should be sought for, because of the wisdom and experience sometimes make a big difference in making quick decisions. Quick and clear consultations with well-defined objectives, whom to talk, which surgeon, what exactly you want. So you have to be very quick and clear. It's not like writing a long one-page consultation to the other specialty. You quickly pick up the phone, tell them this is the situation, this is what we want from him. Focused and crisp communication with the family. Don't talk about the entire case, about oncology outcomes. You have to be very focused and crisp with relevant to that particular situation with the family. A quick, balanced, individualized, and shared decision making is the key to success in oncological emergencies. My last slide. We are fortunate to have an excellent setup with Dr. Shushma and her team at IRCH Ames. This is how we approach oncological emergencies. We have a comprehensive cancer center under one roof. We can just walk into any ward or any department within 5 minutes because it's all under one roof. We have a dedicated onco anesthesia and palliative care setup. We have a palliative care integrated into mainstream oncology. We have a patient-centric approach. We don't refer these patients to different specialties. Patient is admitted and everybody comes there and sees them. We just no consultations, formal write-ups. We just call the other physician. We can see immediately within 5 minutes. There's a seamless patient care between specialties. Joint protocols, joint SOPs are being developed along with other specialties, oncology specialties. We have interdepartmental rotation of team members. This is very important. A palliative care trainee should work in medical oncology and surgical oncology for some time to get a perspective how the thought process and how the departments work. And a good bonding and understanding among the specialties is key for the success. I think with that, I would like to end my talk, and we have only 10 minutes. We can take some questions. This is a vast topic. I tried my best to cover the important issues in 40 minutes. Thank you very much.
Thank you, Dr. Dev. You have covered a lot and you have given a very focused, clear indication that how if an integrated surgical oncology program is in their team, how it can be beneficial for the patients. So Arun, there are many questions. Go please one by one.
Yes, thank you, Dr. Dev. Most of the things have been covered, but we'll take very short questions. So number one question is, how is the survival outcome and quality of life in surgical interventions in bleeding cancers?
In bleeding cancers?
Yeah, if the cancer is bleeding, what can surgical outcome and quality of life?
Yeah, again, it's I think it varies from patient to patient and what kind of tumor you're dealing with. Suppose if it's a breast cancer, which is bleeding, and it's a luminal sort of cancer, surgery can treat the bleeding, but you need to have a good oncology options available, either chemotherapy or radiotherapy for a good long-term outcomes. So it depends on the cancer, like prostate cancer, breast cancer, sarcomas, the long-term outcome is good. Whereas when you come to head and neck cancers, bleeding head and neck cancers, bleeding thoracic malignancies, the outcomes are not very good. So it varies from patient to patient, type of cancer, and what kind of other options available with you. So they make a big difference.
Yes, thank you. So the next question is about rectosigmoid obstruction. If stenting is not available in rectosigmoid obstruction and the patient has a poor risk, what can we do?
The simplest option in you see, stenting is not available in most of the situations. And the simplest option is to do a simple diversion colostomy or ileostomy. So, which is not a very major surgical procedure. You tide over the crisis, relieve the obstruction. Either you can do a transverse colostomy or a ileostomy. Any general surgeon can perform this procedure.
Thank you. So next question. If a patient has radiation cystitis or radiation proctitis and comes to ER with massive bleeding, can an arterial embolization be tried?
You see, these are normally arterial embolizations work when there is a specific bleeder and there is a limited number of feeding vessels. These are diffuse bleedings because of the mucosal damage, proctitis and cystitis. So embolization can be attempted, but what will help better these patients is a sort of a topical sort of therapy, like endoformalin therapy, which can cause a chemical cauterization surface, or you can use APC, organ plasma coagulations. So these are more effective and simpler options than angioembolization. First, you must understand the mechanism of bleeding, because in radiation cystitis and proctitis, it's a diffuse mucosal damage.
Yes. Sir, in your experience in subacute intestinal obstruction, which comes after recurrent cancer of ovary, is there any role of surgery in such a case?
Yeah, that again depends on the, like a freshly diagnosed ovarian cancer, single site obstruction, patient is salvageable, yes, surgery has a role. The same time, if you have a patient of a terminal ovarian cancer, heavily treated with chemotherapy, multiple surgeries, and multi-level obstruction, then the role of surgery is limited. Because in ovarian cancer, these kind of obstructions are terminal events. So every patient needs to be decided on the individual merits of the presentation. And we have certain situations where surgery can help, and we have certain situations we don't like to go in especially advanced ovarian cancer, multiple obstructions, heavily treated with chemotherapy, and already had multiple surgeries.
Thank you. Sir, another question, I think last question.
Yes.
The role of surgeons when there is an extensive and painful oozing raw areas after mastectomy and patients are on chemotherapy. What can we do for that oozing and the raw wound areas?
Yeah, these are difficult to manage, especially the locally advanced breast cancer. What happens, they present with skin involvement, and subsequent to chemotherapy, it can fungate. So initially, if they are responding well, you see there are two situations. One is responding well to systemic therapy, but bleeding. The other is not responding well, they're progressing. In patients who are progressing with these kind of tumors, we normally offer palliative surgery. You remove that fungating or a oozing tumor, then you try to cover it with a flap. In patients who are responding, we can manage with conservative management, wait for them to respond completely, then you can handle the wounds. Raw wounds otherwise depends on the extent of infection, what kind of oozing. It's a topical dressings, antibiotics, painkillers. These are the common sort of a treatment approach we recommend.
So there are no further questions. Few comments like congratulatory comments. It's very excellent and a lot of materials covered in such short time. So thank you for that.
Thank you.
And no further. There are some comments. I'll just take one comment from Stanley. Stan.
Sure. Yeah.
So Stan says that thank you, Dr. Dev, for exhaustive and excellent coverage. He's saying that it is better sometimes to avoid the term passive euthanasia and use withholding and withdrawing of life support instead.
I agree. That was, I think, the right word to use. So I didn't get it. I was preparing my slides yesterday. So yes, I fully agree with him. That's the right word.
We don't have any more questions and comments, madam. I think you can please take over.
So thank you, Arun, and thank you, Dr. Dev, for excellent presentation. And it's like you have covered a lot in 40-45 minutes. And what I can see that over a period of time at IRCH, we have developed a team where patient is on the top, patient-centric approach, the way we have developed, there is hardly any, within 5 minutes, we can call anyone and patient can be benefited. And everybody is thinking on the same direction. And the way you have, I think it will be really helpful to, for all the PGs and the youngsters, that disease specific target things, treatment is specific. So what you have given the overall how they should make their plan and their goals. I think it was fantastic, and thank you very much. And I hope that whosoever is listening, they must be having this kind of a team, but definitely they should try to make a team. Team really makes a huge difference. It is not necessary that patient has presented with emergency means he is not salvageable. There are patients who survive for a long time if proper team management is there. It is not there that all patients are palliative patients, like end of life care patients. So integration of, this is what integration of palliative care is, that you can integrate palliative care, and in the palliative care you can integrate surgical oncologists and various other specialties by good team management and by good understanding. Thank you very much, Dr. Dev. It was such a big opportunity hearing from a leading surgical oncologist of this country, what exactly the palliative care approach of the patients and how a team approach can make a huge difference. Thank you very much.